Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We're so happy that you chose to spend some time with us, and we are looking forward to spending time with you, discussing several topics. First of all, in case you didn't know, June is Men's Health Month, and in observation of that, in our way of doing it, we have a guest today by the name of Dr. Brian Stone, who is going to talk with us about men's health. And then we're going to have some additional continued updates regarding community safety. And without further ado, I'll turn it over to the founder, Dr. Randall Maxey.
Well, thank you very much, Dr. Barbara Stevens, and my favorite psychiatrist that I keep on call at all times, Dr. Ivan Walks, our co-moderator, and Dr. Hines, and we welcome Dr. Brian Stone. And we are going to have some fun today and discuss some very serious, even though not fun, topics. But I thought I would welcome everybody to a pre-Father's Day. You know, they start Christmas marketing 6 months ahead of time. I want to start marketing for my presents a couple of weeks ahead of time. So Father's Day is coming. Is that right, Dr. Walks?
Absolutely, Dr. Maxey. It's interesting. The work we have to do as fathers is every day, but we get stuff one day. I have to lodge a complaint about that.
Well,
we'll take that offline, Dr. Walks.
Good. I want to start off our program before we get to our speaker just about my experience over the past 3 days. I have become an absolute expert at Paxlovid. This pandemic is not over. Our hospitalization and exposures are going up. And I got this not only off of the TV and not only off of what I've seen data, but through personal patients that I've had to start on Paxlovid and or recommend that they receive infusions of immune serum. Interestingly enough, all of the 4 patients that I started yesterday happened to be clergy. I don't know if there's an association that way, but 3 of them are bishops. And I don't know if they don't believe fat meat is greasy, but they're still taking chances. They're still congregating in crowds. They're not masking. They're not doing what they should do. The other thing that I found out, one of my patients, who's one of my favorite patients, is a female pastor. She takes every health supplement in the world. And she was so sick yesterday, I had to call a number of pharmaceuticals in for her. And I just thought, Pastor, what are you taking beside what I'm giving you for your high blood pressure and other medication? She gave me a list of 15 supplements that she's taken, some of which I had not heard of. And it occurred to me that that could be dangerous. Simon, can you put the first slide up? Let's go down to the third slide. So I want everybody to be aware of what's out there. The dietary supplement marketplace is a wild, wild west. It's grown from $4 billion in 1994 when Congress clarified the FDA's authority over products to over $40 billion today. The industry sells over 50,000 different products, many without any evidence of effectiveness at all. Next slide. So dietary supplements, some of them have no clear-cut evidence that they do anything, and some have clear proof of danger. And many of them are have unintended contaminants, and many of them have pharmaceutical agents that are added on purpose to get the effect, but you don't know how much is in it. And many of them are not anywhere near true to what's on the label amount. I was surprised to know that over 80% of US consumers use dietary supplements. And many people that are men use supplements to help them with their so-called manhood. So we know that recently we have turned more to supplements because of COVID-19, thinking that these pills are going to help us against this virus. Next slide. So we know that there's a lot of rampant disinformation. For example, I understand, a defrocked minister named James Backer who's peddling colloidal silver. And there's a leading anti-vaxxer who's McCullough, who's pushing anything he can. But it's very important that we have accurate and transparent information across the healthcare system to protect ourselves. So beware, be alert, and we're going to do a program at a later time on these health supplements. But now, go to the next slide, please. So men's health is our primary topic for today. And it occurs to me, who's the real boss? I don't know if it's the men or not, but the leading advocates for men's health are often the women. That's what I'm told, Dr. Barber. Is that true?
It has been reported that women are in the majority of households, the people who direct healthcare issues.
Well, that's true. Next slide, please. So we're very honored today to have an old friend of mine, Dr. Brian Stone. He's a native of Birmingham, Alabama. He attended Rutgers University. He was accepted into the Morehouse School of Medicine, completing his basic sciences. Then he graduated from the University of Alabama School of Medicine. He completed his residency training in general surgery and urology at the Montefiore Medical Center and the Albert Einstein College of Medicine. He completed a research fellowship in erectile dysfunction and a clinical fellowship in neurourology. He was then recruited to the Columbia University College of Physicians and Surgeons and joined the urology academic faculty and was a member of the kidney transplant team. He was the director of ambulatory urology at Harlem Hospital, my alma mater, and was chief of urology at North General Hospital and chief of urologic oncology at the Ralph Lauren Cancer Center. Next slide. This guy has done so much. It took me 10 slides to get this stuff together. He's the founder of the Jasper Urology Associates, a leading provider of urologic surgery in that area of Alabama. He created the Robotic Surgery program at the Walker Baptist Medical Center. He serves as president of the Northwest Alabama Lithotripsy Center. Just telling you he makes a lot of money too. I'm fooling with you, Dr. Brian.
That's all right.
Because you're my friend. He's been the national president of the R. Frank Jones Urological Society organization, which is an affiliate of the National Medical Association. He was a surgeon for the NYPD. And I'm going to ask him if he carried a gun from 2000 to 2019. He just turned in his shield last year. And he's committed to the mission of bringing more Black and brown kids into STEM and medicine. Thank you, Dr. Stone, for agreeing to be with us today, speaking about men's health. The stage is yours. Dr. Stone?
Yes, sir, I'm here.
Welcome.
Yes, thank you. So men's health is a very broad topic. And being a urologist, I interact with a lot of men. Men tend to be workers. We don't tend to deal with issues until they become an issue. We don't really engage in preventative medicine as much as women. And thus, when health issues present, it's usually a crisis. I find myself in my practice in Jasper. Jasper is about 35, 40 miles northwest of Birmingham. It's in a rural setting, so I take care of a lot of farmers, miners, individuals that work for auto manufacturers, chicken farmers, etc. And everybody is hardworking, and they present to me for one of two things. They're either having problems with their erections or they're having difficulty urinating. And in the midst of the workup, I usually find that their blood pressure is out of control, their diabetes is out of control. Many of them are heavy smokers, have bad COPD, a lot of extreme obesity. So they present pursuing testosterone for what they think is low testosterone, but I find sleep apnea and a host of other issues. So in my practice, I'm not only a urologist, but I find myself being a primary care physician. So I look at men's health in a couple of ways. A lot of our social activities, smoking cigarettes, eating whatever we want to eat, gaining excessive amounts of weight, poorly controlled high blood pressure, and those things lead to issues related to erectile dysfunction, low testosterone levels. I put the prostate in a separate category because what happens with it is kind of out of our control. But a lot of men tend to ignore the issues associated with the prostate until it's a significant problem. So as it relates to social behaviors, I go out of my way to try to deal with nicotine abuse. Nicotine is probably one of the biggest threats to a man's health. And it leads to significant damage to the blood flow that's needed to have an erection. So I've seen a shift since moving from New York City to Alabama in the age of men that are presenting with problems with their erection. I used to see it more like guys over 50. I'm now starting to see young men in that late 20s, early 30 age group. The common denominators are obesity, nicotine abuse, both oral and smoking, sedentary lifestyle, lack of exercise, so things are starting to happen early. So I try to focus on, number one, eliminating nicotine. I've tried to use Chantix, but Chantix comes with its side effects, nightmares, and some unusual psychological issues. And it can be effective, but trying to break that addiction to nicotine is very difficult. One of my most successful treatments has been the use of oral green tea chew. They make a green tea tobacco that I've used to try to substitute for the tobacco. For long-term smokers, the act of smoking or chewing is an oral type of behavior. And so if you can substitute something that's less toxic than nicotine, I've had a great success with doing that. Once we get that under control, it kind of makes the treatment options that you have for erectile dysfunction more effective. I found that many young men have moved away from exercise. When I was a young guy, I played basketball up until my 30s. I mean, we were active all the time, but this new generation, they're not that active. And when you try to encourage exercise, it's not readily received that well. And they usually tell me, well, I do a lot of walking at work, And they try to equate the activities of work with exercise. So that's been a big challenge. But once you deal with controlling the social issues as much as possible, the treatment options now are the oral therapies, which I'm sure you're all familiar with: Viagra, Cialis, Levitra. They've had a new oral agent called Stendra, and there is a sublingual dissolvable Levitra called Staxin. These agents, they work decently for somebody who doesn't have significant vascular damage. And then when those things don't work, we move toward injectable, directly injecting into the penis some vascular dilators. We call it trimix. It's a combination of three things. Not everybody can inject themselves in the penis, and it works pretty well for some patients, but in those with very severe blood flow issues, that doesn't work. And then your next option is the internal pump, I call it, or the penile prosthesis. There are some new treatments on the horizon. I've been working with two. One is a focal shockwave therapy. It's called CoreWave. It's basically a small lithotripsy machine. There's been data that's shown that the focal shockwave therapy causes the ingrowth of new blood vessels and can improve blood flow. And I incorporate plasma-rich platelet therapy. We basically spin down the blood and take out the white layer. And within that, there's some stem cell agents that can enhance the response to the shockwave therapy. On the research horizon is actual work with stem cells for ED, which hasn't been approved in the United States yet. Moving on to low testosterone, highly linked to obesity. Men tend to deposit fat in the gut, and gut fat produces an enzyme called aromatase that will convert our testosterone into estrogen. The treatment, I think it really needs to be done by somebody who has experience in dealing with testosterone. I find that a lot of men are going to GNC, and there's a lot of commercials of all these different supplements, like you spoke about, Randall. These agents haven't really been studied, aren't that effective, and may have side effects that the person may not be anticipating. But low testosterone starts with trying to get men to lose weight. I would say Alabama has some of the largest people I've ever seen. I mean, I thought that what I saw in New York City was obese, but we see average 300 to 400 pound people on a regular basis. So obesity or morbid obesity is a major contributor to low testosterone. I've also seen a shift in the age. I'm seeing a lot more younger individuals who are presenting with low testosterone in their 20s, and at an age when they're trying to remain fertile and have children. So I start with trying to modify social behaviors, try to get them to lose weight, which is a challenge. I've been incorporating the ketogenic diet and the DASH diet into my routine with these patients and trying to get them to lose weight. Lap band surgery is very popular where I am, but it doesn't solve the problem because many of the patients have had the lap band surgery and they present with obesity. So they're eating through the surgery and not dealing with the psychological issues of why they eat. So I'm having to work with obese people and try to manage the testosterone. My primary go-to treatments are the injectable. I'll do depot testosterone, 200 milligrams every other week. Some individuals have tried the one dose a month, 400 milligrams, but the problem with the injectable is that you don't get the physiologic continuous level of normal testosterone. So you get a peak and a drop. So there's been a newer injectable that came out called Xiosted that comes in a injection type platform that a patient can give to himself, and it's a sub-Q versus intramuscular injection. But with the injections, you really kind of need a weekly dose to try to get a therapeutic sustained level if you're trying to eliminate that feeling of fatigue and low libido. Oral agents still under study. There are two. I tried one that came out last year. It's not that effective. The topical agents, androgel is the main one. It's a gel that you apply to yourself. The problem is the more obese you are, the less effective the topical is. There is one agent that you rub on your thighs, one on the chest. There is a patch that it's effective, but again, the more obese you are, the less effective it is, and a lot of patients have a rash from the patch. There are the pellets, sub-Q pellets that you inject. The attempt is to try to get you a longer acting agent to reduce the frequency of interventions. The Testosterone pellets, they work well, but the more obese you are, the shorter the duration period. So it's variable anywhere from 3 months to 5 months, depending on the degree of body fat. Those are pretty much the main things when it comes to testosterone. The biggest danger with synthetic testosterone is overstimulation of the bone marrow, causing an overproduction of red cells. So you see polycythemia quite a bit in these patients. That is where the risk of stroke and heart attack comes from.
What is polycythemia, doctor?
Polycythemia vera is a overproduction of red blood cells, making the hemoglobin and red blood cell count significantly higher. Usually the hemoglobin, the upper limit of hemoglobin is close to 15. Upper limit of hematocrit is in the upper 40s. Some of these patients present with hemoglobin of 17 to 18. Red blood cell count significantly higher. So you have to refer them for therapeutic phlebotomy where they go and donate blood. But the hematologists don't like patients to donate blood because you run the risk of creating iron deficiency anemia, even though they have excess red blood cells. So the management of low testosterone really needs to be done by somebody who's staying on top of this to reduce the risk of the side effects that can occur. But low testosterone is a big deal, and men need the testosterone for energy, muscle tone, and sexual desire. The prostate is the next issue. It's out of our control what happens with it. Prostate enlargement starts around the age of 30 and progresses until we die. The location of the prostate is below the bladder, and the urethra, which is the tube that we urinate through, passes through the center of the prostate, much like a straw through the core of an apple. The pelvis of the man is narrow, so the prostate can only grow outwardly a certain amount. So you begin to get inward growth and compression of the urethra, which leads to the symptoms of waking up at night to pee, reduced caliber of the stream, frequency like less than, I'd say, 2 hours. I mean, a normal person should be able to go 3 to 4 hours before they need to void. So increased frequency, urgency, urinating on oneself before you make it to the bathroom, burning, blood, intermittent flow, having to strain to urinate, deviation of the stream. All of these things are the result of prostate enlargement. So the earlier you intervene in the process, the better your response to the treatments. They have medications. I'm on them myself. I'm 62. I recognize I was having issues. I hate waking up during the night. So when I started waking up more than twice, I put myself on the medications. There are two standard medications. One is, we call it an alpha blocker. Many people know it as Flomax. There are a few other options, Uroxetrol, but they all work the same way. They relax the smooth muscle in the capsule around the prostate. And the goal is to try to allow things to open up, reducing the compression of the urethra. And the other one is what we call a 5-alpha reductase inhibitor. There are two of them, finasteride and Avodart. 5-alpha reductase converts testosterone into its active form, dihydrotestosterone, at the prostate. This is the agent that's responsible for prostatic growth. When you block it, you'll get a reduction in size of the prostate of about 1/3. Several studies have shown that when you're on the combination therapy, it'll reduce your risk of needing prostate surgery for BPH by about 70%. There's been some controversy about the 5-alpha reductase inhibitors, that they may increase your risk of getting an aggressive form of prostate cancer. That was disproven. And the issue is that the Gleason scoring was not designed to look at prostate cancer cells that have been exposed to a hormonal effect. So DHT, by blocking DHT, you're kind of possibly altering the way the cells look in patients who are discovered to have prostate cancer, but it does not increase your risk of having prostate cancer. It actually reduces your risk by about 29%. When the prostate enlarges to a point that it doesn't respond to medications, we have some minimally invasive options that are available. Your urologist will know what to offer you. My go-to has been something called Eurolift Implants. There are these tiny titanium implants that you can pop in the prostate to open up the urethra. You can get up to 8 to 9 years out of it before you need to go to something more invasive. But the management of enlarged prostate really depends on your degree of symptoms, how large your prostate is, how old you are, and the findings on bladder function testing, something we call urodynamics. So as far as men's health goes, those are the main things. And then we look at prostate cancer early detection. Checking a PSA is part of the workup for somebody with symptoms of an enlarged prostate. There's controversy over the use of the PSA. The United States Preventative Services Task Force gave it a D grade a few years ago. That had a negative impact on primary care physicians doing the testing. When they corrected their error, they really set us back by several years, because we started to see more men now who are already reluctant to get their prostate checked, coming in with higher PSAs, more advanced prostate cancer at discovery. I think right now we're getting back on track as far as more primary care physicians recommending and checking PSAs. The position of the Black urologist of R. Frank Jones has always been early screening. I think it helps to at least get a baseline PSA in your 40s, and even more so if you have a family history of prostate cancer. We've definitely identified a genetic abnormality that tends to appear in families where you have more than 2 to 3 first-degree relatives who have had prostate cancer. And the presence of this puts you at a much higher risk of getting prostate cancer and getting it at a younger age. So my feeling is that the earlier you know, you have all your options on the table. The treatment of prostate cancer has evolved quite a bit. We now have robotic surgery. I'm doing cases quicker, no blood loss, sending patients home sometimes the same day, if not the next day. The catheters coming out within 5 days. The 8 times magnification on the Da Vinci robot allows us to perform a much better nerve sparing surgery, which is preserving the nerves for erection when it's appropriate. The rate of incontinence postoperatively is much lower. And then the radiation treatment has improved. We're getting much more focused radiation therapy with less side effects. Brachytherapy remains an option. That's the placement of radioactive seed implants. I'm on the fence about I perform cryotherapy, which is freezing the prostate, but that's more for patients who've had radiation therapy and have failed. HIFU hasn't really taken a hold. It's high intensity ultrasound, focused ultrasound therapy. The whole theory of that was to, instead of taking the prostate out, we were trying to come up with focal therapies to target prostate cancer cells. One of the challenges has been coming up with a diagnostic tool that allows you to see prostate cancer cells and it be accurate. Right now, I use MRI technology. It's still not perfect. The Pyrad scoring, which is the way you score what the prostate looks like and what cells are at high risk and what you may need to biopsy. It's accurate, but it would need to be 100% accurate for focal therapy. So focal therapy is what everybody's looking at, but it hasn't quite made it. One of the biggest challenges with prostate cancer has been hormone-resistant metastatic prostate cancer. And these are patients who, this is advanced stage prostate cancer. They've had the hormone therapy where you block testosterone to try to shrink and control the cancer, but the cancer cells have figured out a way to grow. And so this has been the big focus. There are quite a few new medications out. We're incorporating genetic testing to get a better understanding of the genetics of the prostate cancer. So in certain patients, you can do a very specified treatment to try to control the cancer. So I kind of gave that a whole lot in a Reader's Digest version, and a lot of things I didn't cover, but I think that covers men's health in a nutshell.
Well, thank you very much. I appreciate what you've given us. I'm going to start the question off before I turn it over to Dr. Neighbor Stevens, who put a lot of thought into this. She's one of our bosses. Or am I saying she's bossy? Which one am I saying? But I'm a high blood pressure. Was that Dr. Neighbor Stevens?
You will pay.
So I'm a high blood pressure doctor. And one of the main points I get of resistance when I go to treat patients, male patients with high blood pressure, and we know that by reducing blood pressure to the standard of 120/80, we can reduce stroke by as much as 35 to 40%. We can reduce heart failure by 15 to 25%. But they always say, doctor, will this blood pressure medicine affect my nature? Will it stop me from having sex? Would you comment on that?
So that remains a challenge, and there's definitely a cultural difference that I see between my white patients and Black patients. I mean, the white patients tend to be a little bit more compliant with taking their medications than the Black patients. When I can, I try to reinforce to the patient that number one, if you have a stroke or you die, you're not going to be able to have sex anywhere. So you might as well control the highest risk component of what's going on, and then we'll try to either adjust the high blood pressure medications, or we treat the ED the best way we can. I really try to reinforce to patients that it's so important to get your blood pressure low, especially the diastolic blood pressure, to reduce the risk of renal failure, which we see a lot of. And it's a challenge, but after reinforcing it over and over, I can get people to cooperate. But it's definitely a major issue.
Okay, Dr. Neighbor-Stevens?
Thank you. I have a question that I've been too lazy to do the research and get the answer myself, but so I'll just be honest. So I'll take advantage of your expertise. I've noticed 2 advertisements, and I move back and forth between Nashville and Tampa, and it's on both. I've seen it in both cities. Mm-hmm. One is an advertisement where the spokesperson does not identify themselves as a physician, nor do they ever refer to a physician. And they talk about their ultrasonic technique to increase vascular flow. And the other ad that I've seen, and they don't explain what it is, they imply what it does. They don't really say that either. So they're very careful in what they're presenting, but it's the Roman cure, whatever this is that the Roman guy picks up and takes with him into the bedroom. So could you please, for me and the rest of the lay audience, explain what is going on? And should they even consider it?
Right. So the gimmick of treating ED started with the Boston Medical Group. This group was around when I was in New York. It's been around for 20 years. It was some primary care doctors who basically started a shot clinic where you would go and get the injections in the penis, and they charge you a whole lot of money. So that model was very successful, and it's kind of spread all over the country. We actually have a Birmingham men's clinic that uses the same model. They are promoting something called gauge wave therapy. So there are 2 types of sound wave therapies. The gauge wave is kind of like a piston, a jackhammer that generates shock waves. Almost all the studies that have been published on focal shockwave therapy in the Journal of Urology have been based on core wave therapy, which is more of a shockwave generator based on the shockwave machine that we use for breaking up stones. So it's much less, there's no pain, no risk of injury to the patient, and probably a little more effective. The gauge wave can cause bruising, pain, not as effective, but it's still being promoted. The sound wave treatment isn't covered by insurance companies, nor is the plasma-rich platelet therapy. So they can charge a lot of money. And based on my experience, it's only effective. I would never offer sound wave treatment to somebody with bad diabetes, somebody with known vascular disease, because it's not going to work. It tends to work in patients who maybe have some vascular disease, have started oral therapy. You can convert those back to no pills. And in patients who maybe the pills are less effective, they're going on injection therapy, you can convert them back to responsiveness to the pills. So my recommendation is be careful, do your research, see if there's a urologist involved in that particular office. And if they have no urologist involved, I would be very leery. I would go to a urologist who specializes in erectile dysfunction.
And Roman? What is Roman?
Okay, so the Roman, and they got another one I hear. They are a pill, a company that allows you to bypass going to a physician, and they'll basically do some type of physical exam remotely, or like telehealth, and then they'll send you the Viagra or the Cialis or whatever directly to you.
Thank you.
Yes.
Dr. Walks.
So first of all, Dr. Stone, thank you very much for hopefully scaring us into taking better care of ourselves. Men's health is such a challenge because, I mean, just you don't have to imagine how difficult it is to tell some man, well, we're going to treat your high blood pressure, which isn't bothering you right now, and you can't feel it, and you can't tell it's doing anything to you, but it might kill you down the road. But the medicine we're giving you is going to impact your erection this week. Those are challenges when we're trying to talk with folks about the importance of thinking long term. And my goodness, how hard it is to get people to maintain an appropriate weight. And once again, you've shared with us how intrusive into our lifestyle being overweight and being obese can be. So I want to thank you for that. I want to ask a slightly different question, and then we do have a lot of questions in the chat based on what you've been talking about. In that kind of making the choice thing, I was talking with a friend of mine who is a physician who was saying that one of his challenges with getting people to use their testosterone replacement when they have lab proven, documented low testosterone is that if you increase the testosterone, it can increase the hair loss. And we're not trying to go bald. We're not trying to increase the rate at which we go bald. And can you just comment on if there's a relationship and what the relationship is between testosterone replacement and hair loss? I'm talking about hair on your head.
I think the major cause of hair loss is genetics.
Sure.
Okay. You do have some hair loss that may respond to, they have one drug, alopecia. It's based on finasteride. It's just a half dose that blocks DHT. But I have not really seen a significant connection. And then most of the men who come to me, they're less concerned about hair loss and more concerned about energy level, libido, and muscle tone. Something I forgot to mention is that in the age group of men who are young and fertile and want to have kids, you do not use testosterone. Synthetic testosterone is going to make them infertile. So I use HCG. HCG stimulates the hypothalamic pituitary chain to stimulate the testicles to make testosterone. It's safe, it's effective. You don't have the risk of polycythemia that you get. So that's one of my recommendations. And you can get it. It's called Pregnil, comes in 10,000 unit vials. I give 500 to 1,000 units per week, and it's injectable. The patient can inject himself, and it's very effective. I've used it myself. My testosterone got low, and at one point, it just kind of jump-started me to making testosterone normally. And that does happen a lot. You know, you can stimulate, you don't need to have a person on replacement long-term. Their bodies may restart. But I hope that answered your question.
Yes, sir.
Thank you. You want to take some of the questions in the chat, Dr. Neighbor-Stevens?
All right, I sure will. The first one was clarification on polycythemia vera. Is that a form of cancer?
No, it's not cancer. It just means that for whatever reason, the testosterone is stimulating the bone marrow to make more red blood cells than it needs. It's almost like the bone marrow thinks you're anemic and it's just pumping out red blood cells. You can be placed, I'll put a lot of my patients on aspirin to give them some protection, refer them to get do a therapeutic phlebotomy, which is donate blood, and we keep it moving. But I just monitor them very closely.
So when you say give them an aspirin, Dr. Stone, you mean that by having polycythemia, they would be at higher risk for blood clots or things like that?
I think so. It's my belief that they are. So I don't wait to find out. I just, put them on some type of preventative coverage just in case, and have them donate blood. Periodically, I'll stop the patients from doing replacement therapy until things calm down, and then we'll start it back again.
And the reason I interrupted with that question is so many times we talk about the clinical or scientific condition, and what motivates people is, what's it going to do to me? Is it going to hurt me? Is it going to kill me? And so I always like to get to that. Well, this is what the numbers say. Okay, doc, tell me what that's going to do to me. Why should I care that this number is high or that number is high?
Mm-hmm.
Another interesting question that we have is related to the effect of COVID and the development of erectile dysfunction. What is the current scientific view on that?
I haven't seen any papers yet. I'm sure it's coming, but I can say that I've had quite a few patients who had neurological side effects from COVID. Saw a man this week who's wheelchair bound as a result of COVID. So if you can have neurological side effects from COVID, or if you can have strokes, embolic phenomena from clotting that result in stroke and other potential neurological issues, you can definitely have ED. So it would require a good workup. Part of the workup I do is a Doppler study of the penis where I can check the blood flow, and we do some things to try to arrive at a diagnosis. And in a post-COVID patient, you could probably arrive at whether it was connected or not with the proper evaluation. So if somebody's concerned, I'd say go to a urologist that specializes in ED.
I think Dr. Steiner had raised that issue before. I don't know if he was being humorous or if he had read something on that. Dr. Steiner, would you comment on that issue of erectile dysfunction with COVID? Can you unmute Dr. Steiner? Dr. Steiner, can you unmute yourself? Okay, I guess not.
So just to give another answer, erections are a neurovascular event. So any condition that could affect the nerves to the penis, the arteries, or the veins could result in erectile dysfunction. And COVID has proven itself to be it affects everything. So erectile function would not be off the table.
And one of the items in the chat does reference an article focused on exactly what you just said, Dr. Stone, which is that with those very small veins in the penis, and we know that COVID absolutely attacks just about everything, including the vasculature, that there's no reason why we would expect it would not impact that area.
Doctor, what are some of the dangers of going to the health food store to get help with your erections? And testosterone and other things? What are some of the
Well,
contraindications?
I think I see it a lot. You know, everybody, all of the men, they're using every type of herb they can think of before they get to me. The problem with the nutraceuticals, as you stated, is that they're not FDA regulated. There's no clinical trial process that is required for them to study it and prove that it does anything that they say it might do. They've gotten very good at parsing the language so they don't cross the legal line of saying that they cure something. We've kind of had this problem for 30 years. All I can say is the more common things I deal with, saw palmetto, Africana pygium or black root for BPH, lycopene for prostate cancer prevention, L-arginine for ED, and a host of other things mixed in, ginseng and everything else that hasn't had any proven effect. There was a very large study done looking at the BPH related herbals, Africana pygium, saw palmetto in Canada, and it showed, and they did a few thousand men in this study, no more effective than placebo. I was PI on a study at Columbia looking at zinc. I forgot the other vitamin that at one point, vitamin K or something, vitamin E as being something to use. And we had to stop the study because of the side effects from the vitamin E. So all I can say is that you have to be careful when you are somebody who maybe has prostate cancer, which is a cancer is something that you can't afford to lose time. Testing out things for BPH and ED not going to hurt you. It'll just delay you getting to the right answer. But with prostate cancer, doing things other than what has been tried and proven could cost you your life. So
we should caution people about going to pick up the bottle of Mighty Man.
Yeah.
Now, the other thing, and patients ask, go ahead.
Could I follow up on that? So yes, absolutely. We don't want to miss cancer until it's too late. But would you comment? I don't know that the lay members of the audience would necessarily know that there has been controversy over recommendations to African-American men on as to when they should get tested. Right. And I want to give props to your society that led the fight against this bad advice that U.S. Public Health Task Force was giving. Yeah. And could you just state clearly what the recommendations are as far as African-American men, when they should start getting their prostate checked for cancer?
Okay. Being a member of the R. Frank Jones Urological Society, we've always kind of been considered the rebels, but we're Black. And so we deal with African-American men who continue to have the highest incidence and mortality rate from prostate cancer in the world. We are completely underrepresented in all of the trials that have been done that have been being used to base the recommendations on. So our position has always been that African-American men and men who have more than 1 to 2 family members with prostate cancer, that they start getting PSAs at the age of 40. Now, granted, at the time that they do it, you do provide education about the PSA blood test and what the elevated level might lead to in the process of the biopsy, et cetera. But with the introduction of the MRI into our screening armamentarium, it's kind of reduced the need for the numbers of biopsies that we were doing before. It's important to have a baseline PSA because it's not the absolute number as much as the PSA velocity, which is the rate of increase. So an abnormal PSA velocity is increase of greater than 0.75 nanograms per milliliter within 12 months. The only way you're going to know that is by getting sequential PSAs and having somebody monitor it. So you could have, I've had patients come to me, the PSA was 0.5 last year, and they come back and it's 1.75. Well, that's a red flag to me. Now you have to incorporate age, because the way you deal with somebody that's 70 years old and older is different than how you're going to deal with somebody between 40 and 69. But the MRI, depending on the patient, helps you determine whether or not a biopsy is indicated. I had mentioned earlier the Pyrad scoring system on the MRI is very similar to a mammogram. They will look at spots in the prostate and grade it from 1 to 5. 4 and 5 Pyrad scoring are suspicious, need to be biopsied. 3 is in the middle, 1 and 2 is you don't worry about. But the PSA, the absolute number, the rate of increase is what you look at. The number should be less than 2.5.
So the PSA is not an exact test for cancer, it's a test for inflammation, is that correct?
Yes.
Now,
So there's some nuance to it. Like if I get a 69-year-old guy, PSA is like 3, which is kind of abnormal, but I don't have any other PSAs before, I will put them on a 5-alpha reductase inhibitor, finasteride or Avodart, have them come back in 90 days and repeat the PSA. If the PSA drops by 50%, that elevation is from BPH. If it remains elevated or it goes up more, that person needs to be investigated for prostate cancer. So you kind of need a urologist who kind of knows how to perform the nuance. The high risk group, I would say, is between the age of 40 and 60. Because that's the age group where if you got prostate cancer, early detection is going to have a significant impact on life expectancy and quality of life. So those are the people I worry about. And now that we're seeing people live like into their 80s, even 90s, the 70s, they're still young people. So if you got 10 years of good life left, you want to know if you got prostate cancer so you can deal with it at the earliest stage possible with all the options on the table so that you can preserve your quality of life and your life expectancy.
let me ask another question I get asked a lot.
Yeah.
In terms of forms of treatment for documented prostate cancer, what are the options? When I had that problem back in 2005, I had a radical surgery. Are there other options on the table now that are just as good, or what's your advice?
So with the use of the MRI now, we've started using more observation in selected individuals, and then you follow certain patients every so many months, checking PSAs, doing MRIs, and when the cancer shows a behavior that is starting to progress, then you treat. Radical surgery performed robotically is still top of the list for localized cancer, gives you about a 90% 15 to 20 year long-term disease-free survival. But there's nuance in that because depending on the Gleason score, there's some algorithms that have been developed to help you determine who's at high risk. But the problems with these damn algorithms is that they're based on data from white men. And so they don't really apply to African-American men. So you know, nuance. Still brachytherapy, the radioactive agents haven't changed much. Still radioactive iodine, palladium, cesium. I'm still using iodine 125 C, still effective. Combination therapy remains the most effective radiation treatment. Radiation therapy, I don't have an issue with it in individuals who don't have many biopsies positive. So when we do a prostate biopsy, we'll do 12 cores from the prostate. And if you have a region of interest detected on MRI, you target that, take 3 from each one of those, and I still do 12 random. And so out of the number of cores, there could be up to 18, 20, whatever, depending on the percentage that are positive. If it's not a lot of cores positive and the Gleason score is reasonable, the national average Gleason score is 6. The score goes up to 10. Gleason's 9 and 10 are very aggressive type cancers. The aggressive types, I'm nervous with radiation in young people, but remains the treatment is about the same. We have made it more accurate by doing something called fiducial markers that we place to create a better target. Next, I mentioned before cryotherapy. Similar to doing brachytherapy, we place these cryo probes in the prostate, a worm in the urethra, a worm in the rectum, and then you freeze the prostate to -60 degrees, 2 runs. Cancer cells are resilient, so even with the cryo, cancer cells can grow again. HIFU is being looked at, and heat is being looked at, similar to radio frequency ablation that we do for liver lesions and small kidney tumors. So that's the main things, focal therapy versus the things we've been doing forever.
I know we want to talk a minute about some of your efforts to have African Americans involved in research, but before we do, what are some of the environmental hazards, such as microwave foods, and that affect the prostate or men's health that we need to be concerned about at home?
I think what we know that has the most data is exposure to heavy metals. There were some studies looking at auto workers who were exposed to cadmium. Heavy metals have been shown to increase the risk of prostate cancer. There was a big study done at the Ford auto company that confirmed that. Out of the Department of Defense, they've shown a connection between Agent Orange and prostate cancer. Soldiers who were exposed to the depleted uranium ammunition may have an increased risk of prostate cancer. And the VA has a program in place for those vets who've been exposed and may be at risk. Outside of that, we don't really know. I think the bigger issue is the genetics of prostate cancer. And so a lot of what's going on is a genetic abnormality. And there's a lot of studies focusing on gene therapy, we know that prostate cancer is connected to the BRCA2 gene, the same as breast cancer. So down the road, I foresee a focus looking at gene therapy and attempting to identify individuals young who have that abnormality and maybe doing some type of genetic treatment to reduce their risk of getting prostate cancer later. That's what I see on the horizon.
This has been an excellent discussion. You sent me a slide. Simon, if you can put his slide up and also possibly drop it in the chat. You want to discuss some of the efforts you're doing. I'd like very much for us to talk about that.
Okay. So I think, Randy, you've known me a long time. When I was a young doc in the 90s and the internet first started, I had this great idea to create a company that focused on health information for Black folks called the Black Health Network, and also to recruit Black patients to participate in clinical trials. I created that company based on what we call electronic data capture, similar to electronic medical records. In the old days, I think you probably remember when you did a clinical trial, it was a whole lot of paper. It was forms for this, forms for that, and we created a way to do it on the computer. Well, we were way ahead of industry, and industry wasn't quite ready, nor have they really ever cared about Black folks when it comes to producing new treatments. So I kind of let it go. I got one trial that I did with Amgen on a treatment for prostate cancer, but we could never get traction. So over all the years, even based on that paper that you and Valentine Burroughs wrote regarding underrepresentation of Blacks in clinical trials and why it was so important that we be included, because there are significant genetic differences in the way we metabolize medications. This has implications on dosages, what's considered a standard dose, and the side effect profile. And with the information that's been garnered from the Human Genome Project, you guys wrote that in 2000. We're 22 years later. We know so much more that supports the fact that there are differences between how Asians, Blacks, Hispanics, and whites metabolize drugs. That calls into question how the FDA approves drugs and how they arrive at what's a normal dose and how they conclude side effects and then allow it to be released to the general public. There's enough data to show there are differences in how Black people respond to high blood pressure medications. You know, calcium channel blockers and diuretics work better in us than ACE inhibitors, and there's certain problems you get that occur with one group over the other. But this is all found after the drug has been released, after patients have had potentially life-threatening issues. There was a lawsuit recently that Hawaii won against two major pharmaceutical companies that make Coumadin. The Coumadin was 50% effective in Japanese patients and 75% effective in Pacific Islanders.
What is Coumadin used for? Just to be.
Coumadin is a blood thinner. It's a life-saving medication for patients who've had mechanical heart valves that are prone to creating clots, patients with atrial fibrillation who can create clots in their heart and throw out thrombi, which are smaller clots, patients who maybe have had COVID-19 and have had diffuse clotting, patients who've had deep vein thrombosis, which is clots in the legs. So it wasn't until they started seeing complications in a large number of patients in Hawaii that it was a red flag. And then they find out later that all the studies that were used to develop the blood thinner didn't include Japanese or Pacific Islanders. So they won that suit. So there are issues across racial groups. And when I say racial groups, it's more genetics than how we look. You know, race in America is a thing of your skin color and how you look versus the real deal is in our genes. So my battle now is to try and force industry to deal with diversity and inclusion in clinical trials. The other issue is the industry has always made it an issue of an inability to recruit Black people in the trials, but it's deeper than that. They've created a system where there are no Black researchers. You don't see the PIs on most of these major trials being represented by us. At the table in the pharmaceutical companies, when decisions are being made on what trials to perform, you don't see us at the table. And thus they tend to follow the same pattern of going to the big universities. You know, they recruit the same patients. we are always underrepresented. One of my, go ahead.
Dr. Walsh was the medical director of a major public health department in DC. I'd like his take on some of the things that you're saying.
I was going to give one more example. This is even recent. All of us see the commercials about Enbrel, the biologics that are used to treat plaque psoriasis. I reviewed, there were 24 major studies with 5,000 patients. And these drugs they're good, but they also potentially dangerous because they can have some bad side effects like causing cancers to occur. Out of the 5,000 patients, they had 138 Black patients. That's not enough to arrive at any significant conclusions about dosing, side effect profiles, or anything, you know. So go ahead.
So absolutely, I share those concerns, Dr. Stone. And I think part of it is when we are in positions of responsibility where we can decide what's being covered, decide what policies are going to be in place. We have to ask the questions that you're asking. We have to be willing to have someone go through the research and see whether this is connected to us. We hear African-American physicians a lot talk about treating things like hypertension is one, where I've heard docs say, well, you know, if you're Black, this may be a better drug for you, or maybe combination therapy is what's better for you, because we know that everybody is not the same pharmacologically. We don't respond the same. So it is important that when we get into positions like that, we ask questions and then we look at the responses. Like you said, this thing in Hawaii occurred because somebody started doing a look behind. Wait a minute, how come people that look this way or have this background are not reacting as predicted? So it isn't enough that we hear, oh, this was FDA approved. Well, that's fabulous and wonderful, but is somebody going to keep looking to see how it impacts our community? So I really appreciate what you're doing. I think many of others of us who are either in public health and public policy, or folks like one of our regular attendees, I think he may be on today, Dr. Lawson. Bill Lawson does a lot of mental health research and is someone who understands that you've got to look behind the curtain and see who's involved in this. I thought I saw Dr. Lawson. I was going to ask him to comment, and I don't see him now. He's probably have to jump off and do some real doctoring.
So, Dr. Stone, how can the Black Health Trust assist you?
Okay, so this is what I'm trying to do. I'm trying to take a different approach because we tend to do things the same way over and over in medicine. One thing I've noticed is that in all my 30 years of practice, no one has ever gone to a large number of Black people and asked them what they think about clinical research and under what conditions they would participate. So we created, myself and my partners, I'm with Dr. Lydell Letzum. He is a surgeon and a pastor in New York. And Dr. Ed Ikaguchi, he's the CEO of AI Cure and Accurian. And so we have a questionnaire. I'm trying to get 5,000 Black folks, male, female, to fill it out, and we'll have it evaluated by a biostatistician to try to arrive at what are the real thoughts in our community about clinical trials. Once I get that data, I'm going to do a faith-based model. I'm working right now with the Church of God in Christ, which is one of the larger Black churches, has over 8 million members. I'm working with DJ Dwight Stone. He hosts a gospel channel called the Praise Mixdown. They're in about 40 different venues. He has over 1.5 million loyal Black listeners all over the country. And I'm going to try to create a faith-based model. It'll be easier to track. So that's what I'm trying to do right now. And then we're going to build something based on the responses and try to come up with something to help ourselves, because I think waiting on them to come and help us is not going to happen.
Maybe in the next week or so, you can meet with Dr. Stevens, neighbor Stevens, and Dr. Walsh and myself, and see how we might work with you on some of this. I think this is a
I would love
very valid issue that we ought to look for. Dr. Neighbor Stevens, are there anything else in the chat we need to answer or
Yeah.
address?
There is definitely one, and I do think it is a commonly held belief. So the question is, don't most men by 70 years old have early prostate cancer? This is a common thought. Dr. Stone, can you please address this?
Not really true. So there was a autopsy study by Dr. Ian Thompson in San Antonio, Texas. They looked at, I know it was up to 9,000 men who died of other causes, broken down into 20s, 30s, 40s, 60s, all the way up to the 90s. And they found that in each age group, prostate cancer was present. And it increased in presence with each decade, but the cancer may not be a cancer that was going to kill that person. So the flaw with the study was that these people died before you could know if the cancer was going to be an issue or not. But it showed that by the time you got to 70, about 50% of the men had prostate cancer, 80s, 60 to 70%, 90, you know, but these cancers may not kill the person. The ones we're concerned about are the cancers that elevate PSA. I find cancers when I do scraping of the prostate for enlarged prostate, and it's just there. The PSA is normal. It's not causing the person any trouble. So just because it might be present in somebody doesn't mean it's going to kill them. So we're concerned about prostate cancers that are going to make your PSA go up. And if you got cancer with a normal PSA, we're not going to know about it anyway. So I wouldn't worry about that.
And then the final one that I'll bring forward is a clarification question.
Mm-hmm.
You went through very methodically the different options available for the treatment of BPH, but could you clearly state what are the indications for surgery? Because as we know, a lot of times African Americans are not given all of the options that they have.
Right. So in my office, I'm very scientific. My fellowship was in neurourology, so I have a urodynamics lab in my office. This is a test where we can measure the pressure in your bladder. The pressure in the bladder should be less than or equal to 40 centimeters of water. I just say 40 millimeters of mercury because that's what most people can relate to. And when you get pressures above that, you're beginning to put your kidneys at risk. You have a valve at each ureter, which are the tubes that connect to the bladder, that protects back pressure during the process of urinating from reaching the kidneys. This valve can only take 40 millimeters of mercury of pressure. When you start getting significantly obstructed, you begin to generate pressures of 75, 100, 150. So depending on the severity of the elevation of pressure, that dictates when surgery should be done. And then looking at that along with the size of the prostate, the shape of the prostate, that dictates which choice is going to be best for you.
Thank you so much.
Yes, ma'am.
Excellent. Are there any other questions in the chat? So I was recently in the beautiful island of Jamaica, and I met one of our members there of our advisory. Dr. Lisa, are you available to comment on today's talk and any new developments in Jamaica medically? Can Dr.
I see Dr. Lisa is on, Dr. Maxey. I don't know if she's able to unmute.
I remember she goes to the beach at the same time she does Black Health Trust, so she may have her feet in the water.
We've been
I
having
think you might be violating, you
We've
might
been
be
having-
violating a HIPAA guideline, Dr. Maxey, on what sort of therapeutic activities Dr. Lisa Kirban-Dawes does in Jamaica.
We've been
Okay.
having some difficulties with getting mics unmuted today, just so you know.
Okay. Are there any other members of our advisory who care to comment on today's topic or any other topic? Dr. Gibson?
I would just comment, Dr. Maxey, Ken Steiner here, Dr. Steiner. This was a great presentation, Dr. Stone.
Thank you.
I think it was just, when I come here, I learned so much, and especially on your talk today, things that I was not aware of, and it heightens all of ourselves here on that have heard you to check our prostate health and to get back in touch with it. And it's something that drifts away quite a bit when things might be normal or seem normal. So
Yep.
Thank you for coming today. I know I'm going to take action on much of what you have said. It was really educational to us. Thank you.
Thank you. It's been a pleasure. I appreciate being invited.
And I would just like to say, this is Dr. Sherrod. The outstanding presentation, a lot of good information. And I actually just went through something similarly with my 90-year-old brother who has BPH, and they were actually getting ready to perform surgery on him. I wanted to ask though, what happened was that he had surgery and the prostate became a problem. And he's had BPH for years, but then he had to have surgery. And after that, he had more obstruction. And so can you kind of talk about the effects of anesthesia or other procedures that can increase the prostate size? And maybe it ended up not going to surgery because I just kind of thought that two anesthesias that close together in a 90-year-old was probably not worth the benefit.
Right. So there's something about getting anesthesia. I see it a lot. And a man who probably has an enlarged prostate and is symptomatic, the anesthesia can trigger the prostate to close up completely and they get urinary retention. I see it a couple of times a week. Usually you can put in a Foley catheter, and if they're not on an alpha blocker, you put them on Flomax. You wait 5 days or so, take the catheter out, and they can urinate. But sometimes in guys who have severe obstruction, that anesthesia will trigger an event that's going to require more intervention. And I still use the urodynamics testing to guide whether or not you need to do something else and which way to go. And even in the elderly who are 90, you can do minimally invasive approaches to getting that channel open. But it depends on the size of the prostate. And I don't let age stand in the way. You know, if somebody has an issue, I don't know many men that want to just keep a catheter, you know,
Right.
So there's a way to avoid placing a catheter or keeping a catheter long-term. I do my best to do that. And, you know, you can find a urologist somewhere. You guys know me now. I know guys all over the country, so I can recommend good people for you anywhere.
Thank you so much. That was very helpful.
Yeah, no problem.
He was able to get the catheter out, and now the question is, what do you do and when?
Get him on medication.
Okay, thank you so much.
Dr. Sherrod, at age 25, how can you have a 90-year-old brother?
I do have a 90-year-old brother. We just celebrated his birthday on May 27th this year. You know, I'm from a family of 11. He's the next to the oldest, and I'm next to the youngest.
Okay, well.
So he's
let's
old
go.
enough to be my father. Got it, Maxie?
Yeah. Very good. So we're ready for our final words. And we thank you so much, Dr.
Dr. Maxey, may I?
Oh, go ahead. Who's that?
Gibson. I would love to thank Dr. Stone for an incredible presentation. I am really excited about the prospects of your efforts to reach Black people for clinical trials. I'm curious to know if you've tried using social media in your campaign.
Yes, yeah, that's part of it. My goal is to do direct to consumer. You know, and instead of letting doctors, we always go to doctors and expect doctors to recruit the patients. I think now with the everybody having a cell phone and COVID pushing us virtual, we should do a direct to consumer approach.
Well, I would love to work with you in your, especially in your project to get the people to do the surveys. So anything I can do to help.
Appreciate it.
Thank you. So as we go to our final comments, Dr. Stone, would you care to give some final observations and comments?
Well, I think as long as they're men, there are going to be challenges in getting them to deal with the most important thing in your life, which is your health. Men are normally the primary breadwinners in their households, usually. And as a result, we tend to just focus on work. And it's important to have the females involved in reminding them that they need to look down and take care of themselves, and the struggle to get men to do it on their own will continue. So we just have to be vigilant, keep pushing. And, you know, if you see something, it's better to deal with it early than letting it become a problem.
Well, thank you so much. And we're going to thank Dr. Walter Rayford for referring you to me. I didn't have you in my new phone book. I'm glad it's back. I knew you years ago, but thanks a lot. Dr. Walker, any final comments, sir?
Yes, Dr. Maxey. First, just to thank Dr. Stone. This is so important. I think I just would like to reach out to everyone who is in a position of influence and have us talk about men's health and how important it is. 3 quick examples. Good friend of mine who I grew up with played basketball for the Harlem Globetrotters, died at age 42 from prostate cancer, died at 42. So this whole thing about getting checked in your 50s and 60s is late for us. And I thank Dr. Stone for pointing that out. Another friend of mine played in the NBA, died of prostate cancer in his 60s. Third one is a good friend of mine who got his prostate checked and got his prostate cancer taken care of in his 50s. And I think he's still out being mischievous now. So I think that there's a huge difference when we do find things early. And I want to disconnect. The reason I use those examples, I want to disconnect this thing about how we have to look sick. We have to be overweight. We have to have something wrong with us. We have to already be getting treated for diabetes or something else before we begin looking at other aspects of our health. It's important for us to do exactly what Dr. Stone talked about and begin getting that baseline information at age 40 in a lot of different areas of our health, so that we can be like you, Dr. Maxey, be running around in Jamaica at your ripe old age of, I think you're over 40 now, right? And you were running around in Jamaica last week. That's what I got. I'm really excited about us talking about things like men's health. So thank you, Dr. Stone, again.
Oh, can I mention one thing?
Sure.
I serve on the executive board with Dr. Rayford of the Conduct Registry Trial. It is going to be the largest African-American prostate cancer registry in the world. It's going to be housed at Clark Atlanta University in their cancer center. We start recruiting in the next couple of months. We're working with Arbormetrics, which is a big CRO. And hopefully big things will come out of this, because all the clinical trials that we rely on to make decisions about treating prostate cancer in Black men, we're poorly represented, and the data is just not in our favor. So we need to look at us. So that's what we're working on.
Well, thank you again so much. Dr. Barbara Neighbor Stevens.
Dr. Maxey, before I give my final thoughts, I have a request for Dr. Stone. There are a couple of people who have expressed the desire to reach out to you. So Dr. Stone, would you be so kind as to put your contact info in the chat box for us?
Yes.
Thank
I'll
you
do
so
that
much.
right now.
Thank you so much. And thank you again for sharing your insight on this important topic with us today. The other part of our topic today was continued updates on community safety. And I want to put the spotlight on two issues that have absolutely nothing to do with men's health, but which are currently becoming the seasonal issue that they tend to be. And these are safety issues involving children. The first that I want to shed the spotlight on is the increasing number of children who are drowning. Now, children drown for lots of reasons. Sometimes those little ones can slip away despite your best efforts to keep up with them. Sometimes it's because they jump into water that is unsafe. They disregard the signs that are posted. And another new issue this year is a severe shortage of lifeguards. So I want to bring the issue of water safety to our community. If at all possible, have your children learn how to swim as early as they can. My mother had my brother and I trained how to swim because my father couldn't swim. And he used to take us fishing all the time. She said, at least y'all can save yourselves. You can't save your father, but you can save yourselves. But, and I say that in jest, but it's serious. And so as we are in the summer months, please share with your circle the need for water safety. The other issue, which is something that has a seasonal thing, is we are distracted. We have a lot of stuff going on in our lives. And unfortunately, we forget that the children who are quiet or sleep or in the back seat, and they get left in cars in the summer and they get overheated and die. And every summer we have numerous cases of this happening. And with climate change, it's not just the South, it gets very hot or hot enough to cause the death of a child in a closed car. Even at temperatures in the 80s, if they sit there long enough, they can die. So it doesn't have to be 102. And the newer cars have reminders now to look back before you leave. But if you don't have one of those, just please, please remember that you've got a passenger in the back and you want to make sure that you take them out.
Well, thank you for that very timely reminder. I'd like to really give thanks to Simon Cooper, who's been our technician and is always making us look good. I just want to make sure we recognize him for his efforts. He's got all these computers that he say are growing hair, and maybe one day we can help him fix those. I'd like to also give thanks to our co-moderators, Dr. Hines, who's not with us this morning, Dr. Walks, and Dr. Neighbor Stevens. And I'm reminded that we lost a giant of a physician yesterday, Dr. Valentine Burroughs, who was a major endocrinologist who had multiple myeloma and succumbed. We don't normally mention that, but he was such a good physician that affected so many lives. And we want to thank his family for loaning him to us for so many years. And our prayers are with them. Wish everybody a good day. Be safe, be happy, have a good day. Thank you very much.
Good day, everyone.
Bye-bye.
Bye-bye.